Recording is in progress. So again, welcome everyone. James, it is in your hands.
Thank you for the warm introduction, Japera, and good morning, everyone, and welcome to part 2 of the Unraveling of ICD-10 PCS. Before we get started on today's presentation, which, as Japera said, is just going to pick up discussing each of the root operations from the medical surgical section 0 of the code set, I wanted to recap because a month is a long time ago to remember everything. And the reason this whole thing got started was I'd given the presentation to onboarding a physician at 3M, and he wasn't getting PCS. And when I gave the presentation, he actually asked me to give it twice. It really stuck. So I said, well, this is worth taking off the shelf, dusting off, and reusing. And I gave it to our Connecticut HEMA group, and then I'd connect it with the qualified, and thought it would be a good presentation for this group as well. Because everybody's hyped up about the move to 11, but we really need to, really fully shine up our understanding and knowledge of what we have now, ICD-10 CM and ICD-10 PCS. PCS is very scientific, it has a definitive architecture. It was commissioned by CMS to 3M to develop. They put it out for bid, and 3M got the bid, and they developed this highly scientific, architecturally solid code set. And they had learned a lot from previous mistakes. ICD-9, Volume 3 quickly became crowded. And in the 80s, when technology and new procedures, new drugs, new approaches really took off, it became very crowded quickly. And one of the main mistakes was including diagnostic information and things like eponyms, because it very much limited an entire category of a code. So when you said liver repair, excision, or hernia repair, that code, if they do some similar type procedure in that area of the body, they can't use that code because it included the term hernia. That was important. Believe it or not, that's highly important, the elimination of anything diagnostic, because a lot of people get hung up on that when they're coding in PCS. PCS is actually very easy to code, and when you look at it without any previous conceptions about how we code, we don't care about why they're doing it, just what are they doing, kind of like Just the Facts Man from Dragnet. Why are they doing this? What's the intent? It's to excise something, to resect something, whatever the root. That's why the root operations are the most important part. And we had said every PCS code always must contain 7 characters. Each characters have very specific values, and those values are consistent throughout to the degree possible. In the med surg section, each section, they definitely are consistent, but from section to section, they do vary because they're not always pertinent or relevant. And we had also pointed out that O and I are not used. There's the only 2 letters not used, so as not to confuse them with 0 and 1. And let me think what else I have to say about that. So it's very multi-axial, and it's kind of like a rubric cube. So very good for research. So if you're looking at a certain procedure and the approach you were looking at was open, now you want to look to see if they had done it endoscopically percutaneous. How are those results? Were the outcomes any better? You could just change one of the characters, the approach character, and bring up all that data. So, or if you're doing any kind of research, even when you're coding, it's just much easier to go in and tweak, adjust, correct than it was in I9. And having 7 characters, then when it's valid code. And at 9, they could be they just have 2, 3, 4. You weren't sure if the code was complete. Now the code is incomplete if it doesn't contain 7 full characters. And the placeholder in PCS is Z. It's X in CM, so as not to confuse those 2 things. Now, I guess we could dive back in. We'd covered some of the major. We had talked about how root operations were categorized, things that remove, things that insert, things that repair, things like that, to chunk it out to make it easier to learn when you're studying PCS. So we're just going to continue our review of the structure, its purpose, its functionality. It was designed as they were developing it. They were thinking about the electronic age and the EHR and research and like population health and things like that, and efficacies and quality measures were just beginning at that time. So it just much better lent itself to doing that type of research. So you don't have to be a researcher, as in some scientists at the CDC. You could be, to quality, working in quality or risk management or denials management. Look to see like what procedures are causing the most problems by looking at individual characters. All right, on to the next slide. So, procedures that take out or eliminate solid matter. This is where we left off. Um, Fluids, gases from a body part. And these three root operations, are the third character. The values for these are consistent throughout the med-surg section. And root operations pretty much everything, because the PCS code that you're assigning is based on intent, purpose. What are they trying to do? Why did they take this patient to the OR? What is it they're trying to do? Drain. They're trying to drain something, extirpate. Extirpation was something newly introduced. We never really used that term before ICD-10 PCS came along. And it's just the only difference is it's solid matter versus fluid or gas. Fragmentation, that's, like shockwave to break up stones, or green light. Well, green light's more destruction, but anything they do to just break something up before they remove it. Next slide. So I'm following the same structured format I had followed last time. I don't know if anybody's new. Is part two is where they're beginning, but I give the definition, an explanation, and then an example. Oh, that's another thing. The reference there is. We'll get to it at the end, but your ICD-10 PCS code book will be your best friend if you don't have a good electronic code finder type thing, encoder, that can create the tables, because it's always good to look at the table to see all of your options. Because if you have a code finder or you use the book and just use the alphabetic, you don't get to see all your options. So there might be a more specific body part, or there might be a more accurate description of the approach, like you might find in the alphabetic index or wherever it is you're looking, percutaneous, but percutaneous endoscopic might be a choice. Or you might say, oh yeah, lung, excision of lung. But when you go to the table, you'll see that right lower lobe, greater specificity in the body part character values is available. So I always like to see my tables. And again, in PCS, unlike CM, the alphabetic index is not required. Going to the alphabetic index and ICD-10 CM is an actual coding guideline. It's not in PCS because the tables are where your information is. And as you code more on the inpatient side, you'll know, like your first character is always going to be 0 when it's med-surg. The body systems like 4s, respiratory, you come to memorize them. So it's very easy. When you have the first 3 characters of a code, then it's very easy to find the table in the actual PCS book. But there are also a lot of appendices to help you find when there isn't a particular code for that device or value for a device or a body part. Those appendices will help guide you there. But these come for a reference that's out on CMS. It's kind of outdated, but it still gives a lot of meaningful information. So the pure definition, it's all about the other virtue or character that's consistent throughout ICD-10 PCS, is that there's standard terminology, and it's all about the definitions. And the definitions for everything could be found in one of the appendices in the back of the PCS book. So that you can't, it's not open to interpretation. You can't say, well, I'm going to use this because I think. Your opinion really doesn't count. It's just the definitions there, and they can't be wavered, which made it good for one of the CMS requirements was our communication as coders with physicians, because physicians like to argue. Well, to me, that's this. Well, it doesn't matter what it is to you. In PCS, this is what that means. So as we saw, like one of the common arguments, excision versus resection. To use resection, they have to take the entire structure, the entire organ, the entire body part. So if there's a value for it and they take the whole of it, then it's resection. They only take a piece, then it's excision. That's your typical argument you get into with physicians. And it also clearly states how important the definitions and how the standard terminology comes into play within ICD-10 PCS. So the definition for drainage is taking or letting out fluids and or gases from a body part. And an explanation is the qualifier diagnostic is used to identify drainage procedures done for biopsies. Remember, the seventh character uh, is where you show that something's done for diagnostics as biopsies, and it's an X. And a common example would be a thoracentesis when they drain fluids from around the lungs, or an IND, an incision and drainage of a abscess. Okay, next slide, please. Next root operation is extirpation, very similar to drainage. There's some gray areas with these two, because if you have like a hematoma, it could be a mixture of fluid and solid, and or not clearly documented, which might warrant a query to the physician, because it does kind of matter. Because with a hematoma, if it's reached the point where it's solid, uh, I wouldn't say it's dangerous, but it's gone on longer and it's the condition's more severe than if it were just fluid or a new hematoma that's just recently acquired and being currently drained. So for extirpation, the definition would be taking or cutting. You could also cut out solid matter from a body part. So extirpation, they could actually cut it out, which you would see like when they do endarterectomies, and they use a little tool, the instrument, endoscopically, and cut out solid matter from the sides of the tubular vessel. So the solid matter may be an abnormal byproduct, like plaque in an artery, of a biological function, or it could be a foreign body as well. So extirpation would be used for removing a foreign body. So if you had like, a shard of glass under the skin and they extirpated it, that would be an example of extirpation. It may be embedded on a body part or in the lumen of a tubular body, like plaque in the case of arteriosclerosis. The solid matter may or may not have been previously broken into pieces, which would be fragmentation. So thrombectomy or a choledolithotomy. I should have picked an easier to pronounce word. So again, it could be the lumen of a tubular body. Some of the root operations that we discussed previously, they make that distinction. It could only be done on a tubular body, but for extirpation, it could be a solid organ, or it could be, a part of a body part, or it could be the lumen of a tubular body. Thrombectomy, good example of that. They go in with a little tool and they kind of like rotor out the arteries of plaque. Okay, next slide, please. Next root operations, fragmentation. We saw in extirpation, they may or may not. So they could break up a stone, then go in and extirpate it. So the fragmentation wouldn't necessarily be coded because it was a means to the end. So breaking solid matter in a body part into pieces. So physical force, it could be manual, ultrasonic, applied directly or indirectly, is used to break the solid matter into pieces. Solid matter may be an abnormal byproduct, like stone. It's not normal to have kidney stones, but it happens, of a biological function, or it could be a foreign body that they need to break up before they could remove it. It's too large. They most likely they want to use the endoscopic percutaneous approach, but the foreign body or the biological substance is too large, so they break it up. The pieces of solid matter are not taken out. So when they remain in, and the body's allowed to just absorb it or move it along, like with stones, they'll break them up and allow the patient to pass them. So that's the difference between extirpation. Extirpation, they might break them up and then go in and take them out. So your final root operation would be extirpation. So extracorporeal shockwave lithotripsy or transurethral lithotripsy would be good examples of a fragmentation. Sometimes they do, I think because of the pain, they might use general anesthesia. They will take a patient to the OR, probably because of anesthesia, like I said, even though they're doing the extracorporeal shock waves to break up, because they might not know what's going to happen. I mean, might dislodge a chunk and it might cause bleeding. So you do see fragmentations done in the OR, whether or not they admit them. It may not, it might be under observation, but the patient can go to the OR for a fragmentation. Next slide, please. So now we're going to talk about procedures that only involve the examination of body parts and regions. And these two root operations are inspection and map. These are nice to have because before they would do a laparoscopy, and it was confusing to coders in 9-9. Do you code it or don't you code it? So if they do this and then they decide to do, so they do a laparoscopy and check things out, and then they take the scope out and they decide they're going to do an appendectomy, you would code both because it's a separate and distinct procedure with a separate and distinct purpose. Mapping, we'll see, that's like cardiac and brain functions. Next slide, please. So inspection, the definition of inspection is visually, so it could be with the naked eye, or manually exploring a body part or region. So visual exploration may be performed with or without optical instrumentation. The doctor could just look you over. Manual exploration may be performed directly or through intervening body layers. They may have to cut sometimes, what they're saying. So a diagnostic arthroscopy would be an example, an exploratory laparotomy. So they do they do those arthroscopies frequently before they decide what they're going to, if they're going to do a knee. So you have pain in the knee, they do an arthroscopy to see if there's a tear, if it's arthritis. They likely will not do the procedure then, but so do we have a way to capture that better than we did before 9? Because it's just purely an inspection with no intent of performing any kind of therapeutic intervention. Next slide. Here's map. So the root operation is simply map. It's not used because a lot of these, well, I shouldn't say that. Sometimes for brain function too, you may be under anesthesia. And cardiac, a lot of times during a procedure, they'll be monitoring what's going on with the heart. And some of them are pretty heavy duty intensive and resource intensive and costly. Some of these mappings are not cheap, is my point. They involve a lot of resources. So the definition for map is locating the route of passage of electrical impulses and are locating functional areas in a body part. This is growing. More and more neurological studies done with musculoskeletal problems, or why something's not healing. So this may be one area of PCS we see expand in the near future. So it's applicable only to the cardiac conduction mechanism and to this central nervous system right now, but that may change. We may do more with the peripheral nervous system, or even as the nerves affect even like the urinary system and the musculoskeletal system and various things like that, even the skin sensations that are abnormal and they can't get to the bottom to, but are troublesome to patients. So cardiac mappings, very good one. Like those EP studies they do, they're very costly. A lot of times they may not be admitted, but they go to the cardiac suite and they're in observations, or cortical mappings for patients experiencing seizures. Next slide, please. So now we have procedures that can be performed only on tubular body. I mentioned these before. So you might think, so this is very helpful to, especially to a new coder. You might want to, I don't know, can't even think of an example, but you might think because they're clearing something out, like even a lung or something, you might think, well, I'll use dilation instead of like drainage or extirpation. But then when you read the definition, you see that it cannot be used on a lung, a body part like an organ. It can only be used on the tubular body. So the root operations that fall into this category are bypass, dilation, occlusion, and restriction. So like I had said at the beginning, breaking it out by these categories of root operations really makes learning PCS. And the way to learn PCS, of course, you can't memorize a code set, but it is good to memorize the definitions of the root operations. That's really where it all begins. If you make up your own little flashcards and maybe one color, like maybe, light green for procedures that can be performed only in tubular bodies, and on one side of that note card, write bypass, and then the definition on the other, that'd be a great way to organize your flashcards and to memorize and learn these definitions for the root operations. Just give the teacher and me giving you little instructions. And it's always better to create your own flashcards than to buy them, because the actual creating of them is a good learning process in and of itself. So let's take a look at bypass. Next slide, please. So the definition of bypass is altering the route of passage. We see that term route of passage a lot because when you think about it, the human body, there's a lot of movement. It's like a highway system. It's like an infrastructure, a lot of things moving around. Neurosynapses, blood flow, lots of things, the lymphatics, urine, waste, lots of things, respiratory, oxygen, of contents of a tubular body. But bypass, remember, is strictly for a tubular body, which could be like an artery, a vein, um, um, your digestive tract. So rerouting contents of a body part to a downstream area of the normal route. It's correcting, so things aren't flowing right, and they're going in to correct it to a similar route and body part, or to an abnormal route and dissimilar body part includes one or more anastomosis with or without the use of a device. So an example would be a coronary artery bypass or CABG or colostomy formation. So that's what they mean by abnormal. So a colostomy would not be the normal flow of things, but it would definitely be a rerouting. And that would be an instance where they would use a device. Colostomy is a good example of that. But typically, a lot with the cardiovascular system, we see bypass, and the digestive, gastrointestinals, where it's used most frequently. Okay, next slide, please. Dilation. So dilation is expanding an orifice or the lumen of a tubular body. So they're not completely clogged, your arteries or your coronary artery or even a peripheral artery, but they're somewhat collapsed or too narrow to give adequate blood flow. So the orifice can be a natural orifice or an artificially created orifice. So it could be already a synthetic. So maybe you've had a valve replacement or an artery, they've used synthetic, you've had a bypass graft already, and the graft is now not quite as open as we would like it to be. So they can go in and do a dilation, accompanied by stretching a tubular body. So they're going to basically stretch it like a balloon angioplasty, using intraluminal pressure or by cutting part of the orifice or wall of the tubular body. So percutaneous transluminal angioplasty is a good example. They go in with endoscopically with the needle. They have a balloon attached. They open that balloon and stretch out the lumen of the tubular body to increase blood flow. Another example would be a pylor myelotomy, which it's any tubular body, digestive, other, but most commonly seen in gastrointestinal and cardiovascular. Next slide, please. So occlusion, so occlusion's a little bit different. The intent here is to close off because of bleeding, or something's wrong, something's going somewhere it shouldn't be going. Completely closing, so you have to completely close it. Completely closing the orifice or lumen of a tubular body part. The orifice can be a natural orifice or an artificially created orifice. So it could be something that was previously put in and now they want to close it off. Fallopian tube ligation would be an example. Ligation of inferior vena cava would be another. It might be an aneurysm or something going on where they don't want the patient to bleed out or have a stroke. They have to cut off or occlude any blood flow from that rupture. Next, please. So this is its sister root operation, restriction. So restriction's different in that it only partially think about it, you might have bleeding, a hemorrhagic stroke, and there's bleeding in the brain. You'd want to restrict that bleeding. You want to cut it off entirely, that you make the patient brain dead, do more harm than good. So partially closing the orifice of a lumen of a tubular body part. The orifice can be a natural orifice or an artificially created orifice. And something like an esophagastric fundoplication is a good one because, again, that's the gastrointestinal. The esophagus, it might be somehow enlarged and or something or bleeding even, and they want to cut it, reduce it, and restrict it. A cervical cerclage is another example where they restrict the opening somehow. But again, it has to be a tubular type body part, not just any organ or if they're cutting off blood flow too. Next slide, please. So procedures that always involve devices. These are good, very important. Might want to make those flashcards a color that stands out like lavender or hot pink, because you tend to want to use these when you shouldn't use them because it has to involve a device. Although device, not necessarily like a pacemaker or a fixation device or a neurotransmitter. It could be biological, like a skin graft or a porcine valve. So these are very important to think about as you're learning them or memorizing the root operations, just what a device entails. And to use a device, to add the device value and that character, that position in the code, the device has to remain with the patient when they leave the OR. There's a lot of instrumentation devices they use during a procedure, but they remove them all before the patient leaves the OR. Like the cardiac monitoring, the mapping and stuff. The patient doesn't leave the OR still hooked up to all of that, so it wouldn't be with a device. Next slide, please, Shapira. So the first of these is insertion. So insertion is just what you would think it would be. Some of these, it's nice too, because these root operations, the standard terminology isn't all that heavy duty medical terminology. A lot of it means what it would mean in everyday lay terms. So putting in a non-biological appliance that monitors, assists, performs, or prevents a physiological function, but does not physically take the place of a body part. So it's just some kind of, and this one is non-biological. So it says, and that's why I can't emphasize enough creating your little flashcards if you are learning PCS and memorizing these things. So for insertion, the root operation that requires a device, it has to be non-biological. Like, so the insertion of a pacemaker would be a good example. So to reiterate, putting in a non-biological appliance that monitors, it can monitor like a Holter monitor, assists like a pacemaker, performs or prevents a physiological function. Well, that would be like a defibrillator, but does not physically take the place of. So it would not a heart transplant. So a heart transplant, with a synthetic heart even, would not be an insertion. You don't just insert a new heart. That would be a transplant. So an example would be even a radioactive implant, an insertion of a central venous catheter. We use these a lot, like a PICC line, a VAD, but even radioactive elements, when they're inserted would be an example of insertion because they are devices, they're not biological, and they do remain in the patient, and they do prevent physiological functions, and they're not taking the place of the body parts functionality. Next slide, please. So next we go to replacement. Replacement's a lot different actually. So the definition for replacement is putting in or on biological. So these for replacement, they can be biological or synthetic. So one or the other are allowed. Non-biological would be synthetic material that physically takes the place. So these don't assist, they take the place. So replacement is literally that. It's taking the place of something and or function of all or a portion of a body part. So like a, a skin graft or muscle graft would be an example. It's not taking the place of your entire muscular system. It's just a part of it, the body part, and it's assisting. It is assuming some of the functionality. So explanation. I did this deliberately. I tried to be consistent, give a definition, an explanation, and then some examples. I think that's a good way to learn. Keep it simple. So the body part may have been taken out or replaced, or may be taken out physically, eradicated, or rendered non-functional during the replacement procedure. A removal procedure is coded for taking out the device used in a previous replacement procedure. So that's good to know. So these explanatory notes are very helpful. So to reiterate, to recap, the body part may have been taken out or replaced previously. So they may not do them. They do that a lot. They might have uh, removed like a hip replacement. Sometimes they get infected very badly. They take them out and they leave nothing in, and they go in later and replace them. So that's why they're reiterating this here. The body part may have been already removed, and they're coming in now to replace it. Uh, and it could be that there's nothing to remove. It may have been eradicated before. But the main thing here is that it's biological or synthetic, and that it physically takes the place of, and typically some or all of the functionality. Because sometimes when they replace something, it'll help, but it's not going to be as good as what you had originally, but from nature. So an example, good example, example's worth 1,000 words. Hip replacement. So hip replacement's taking the place of your natural hip. But it could also be a bone graft or free skin graft. So all your free skin grafts, when they're not attached, if they're attached, pedicle, they'd be transfer, but we'll get to that later. So skin grafts, again, they are taking over the functionality because you need your skin to cover up, the inner workings of the body. But it's just a portion of your body that'll replace your entire integumentary system. So I think these with the devices get complicated. Next slide, please. So next up is supplement. It's replacement supplement. It's a little bit confusing. That's why you really have to read the definitions before you assign the code, especially when you're a new coder. You do get used to them when you're doing, especially when you do audits or you develop content like I do, it becomes second nature. Putting a lot of, depending on the facility you're working at, a lot of them don't do a lot of this. Work for a hospital that deals with burns, you'll be doing a lot of these. So putting in or on biological or synthetic material that physically reinforces or augments the function of a body part. So again, it's different in replacement. That's not replacing it. It's not taking over the functionality. It reinforces or augments the functionality of that body part. So to explain that a little more, the biological material is non-living, or the biologic material is living, like a skin, from a donor or from the patient himself, taking it from a donor site and from the same individual. The body part may have been previously replaced. If the body part has been previously replaced, the supplement procedure is performed to physically reinforce and or augment function of the replaced body part. That's quite a mouthful, that explanation, but I want to give examples that make more sense. So when they do a herniorrhaphy using a mesh, the mesh reinforces, it supplements the procedure. A, a, a free nerve, a free nerve mitral valve ring is another example, or an annuloplasty, or a new acetabullar liner. So you've had a previously replaced tip, and the liner is worn down. So they go in and replace the liner, supplementing that area to strengthen and reinforce it without, removing the entire hip replacement, the entire joint replacement, not a total replacement, just the liner. Okay, next. Okay, removal. Okay, and this again involves device taking out or off a device from a body part. It is what you think it would be. So if a device is taken out and a similar device put in without cutting or puncturing the skin or mucous membrane, like a Holter monitor, the procedure is considered to be a change. You'd use root operation change. They're just switching it out. Otherwise, the procedure for taking out a device is coded by the root operation removal. And then you would also include, if they do replace it, you would use replacement or insertion, depending on which is more important. But the root operation change is used when they're just switching it out. But the caveat there is that they do not puncture the skin. It's kind of an external. The only approach would be external. Uh, Again, a good example would be drainage tube removal. They just pull it out. Cardiac pacemaker removal. Typically, then you would also do the replacement. I think it affects, well, I don't think I know. You'd want to get both codes because if you leave out the removal code and just you won't land the right DRG, the diagnostic related group, or reimbursement or a replacement versus the initial insertion of a pacemaker. Okay, I think next slide, please. So here's change. So change is, so there, you see how they're all interrelated. So like I said, if you had color coordinated, or even if you with a highlighter pen, use all white cards and make a stripe or a band across the top of it in a different color, like orange for things that take out devices, that'd be a good way to keeping them organized while you're learning. So taking out or off a device from a body part and putting back an identical or similar device, they might have upgraded to something more complex, or on this in or on the same body part without, the key here is without cutting or puncturing the skin or the mucous membrane. All change procedures are coded using the approach external. I said the other kind of gave that punchline away. So obviously, the only option for an approach would be external because by the definition, the very definition, you cannot cut into the mucous membrane or the skin. Example again, urinary catheter change, a peg change, a gastrostomy tube change. They just change it out. Take something worn out, they pull it out, they pop the other one back in. It wouldn't be a replacement, it'd be a change. Next slide, please. A revision, correcting, again, involves a device. This is tempting to use. Here's a good example of a root operation that requires a device when you might want it, because we talk about, revision, I don't know, like could be like a hernia repair. They're going to revise. It's a regular surgery on a regular real body part, and something's wrong. The sutures, the wounds to hist or something, and go and revise. They use that term, revise what had been done. But in PCS, revision is restricted to be used only when it involves a device. So be careful of that one. So correcting to the extent possible a malfunctioning or displaced device. Sometimes like the joint replacement is misaligned or, slipped out of place and they go in and that would be a revision. So revision can include correcting a malfunctioning or displaced device by taking out or putting in components of the device, such as a screw. So adjustment of a position of a pacemaker lead, that happens a lot. Or re-cementing of a hip prosthesis. They become dislodged and they go in and they just cement them. Sometimes they don't cement, in the end they realize they have to. Pacemaker leads you see a lot, but it could be any type device that they need to go in and adjust. They don't take it out. They might take it out and adjust it, but they put it back in. So that would be a revision. Again, be careful never to use this when it does not involve a device because it's the temptations there. I've fallen into it. So I think we're ready for the next slide. So now these procedures involve cutting or separation, division, and release. Okay, next. So they don't remove anything. The difference between these, like excision, resection, nothing comes out. So cutting into a body part without draining fluids and or gases from the body in order to separate or transect a body part. So just incise something. They divide it. So they just cut something open to let it breathe or air out or heal. Like a spinal cordotomy is an example, or an osteotomy. All or a portion of a body part is separated into two or more parts. Or it could be scar tissue, eschar, that it's impinging or impairing mobility. So they go in and divide the tissue. But they don't, the key here is they just cut into, it's an incision without excision, and they don't drain anything, they don't extirpate anything. They just go in and make an incision, it's division, and nothing else. So again, it would come how the root operation, how the operative report would be dictated, what the documentation includes, would gear you or steer you into whether it be division or extirpation. So if they go in and they divide, they make an incision, then they remove solid matter, that would be extirpation. So one kind of grows into another. Again, you need a root operation, operative report, or some kind of documentation to know when to use which. Next, release. So the difference here is the intent. Again, part one in the beginning of today's presentation, I emphasize it's all about intent, kind of like the law. What are they meaning to do when they take the patient to the OR? So if the division is something's tight, like a burn, the way the burn or the wound or the injury is healed, and they just go in and make an incision to free it up, or release, that's not a bad word, or like to air it out. They don't, so there's maybe some kind of a growth or abscess, but there's nothing to drain. They just incise it. That would be division. But uh, um, release is a little bit different. The intent's different. It's freeing a body part from an abnormal physical constraint by cutting or by use of force. So adhesiolysis or carpal tunnel is a good one. So some of the restraining tissue may be taken out, but none of the body part is taken out. So that's different. So lysis of adhesion. So they have lysis. They go in to do a hernia repair. The patient maybe has had a C-section, and there's all kinds of tangled up tissue that's in the way. They first have to release the organ they're trying to get at. So that would be release. And they may take some of the material that's constraining it or restricting it, but they don't touch the organ. So that's when it's release. So the intent is a little bit different than it is for division. Release, it's very specific to freeing it up. Next slide, please. To leave some time for questions if there are any. Procedures involving other type repairs, control and actual repair. And repair is kind of like the default. We talked last time extensively about NOS and NEC, not otherwise specified, not elsewhere classified. CMS did not want unspecified or other specified or vague type things, any kind of vagueness or lack of specificity in PCS. So repair is as close as you get. So when all else fails and you cannot find a suitable root operation, you default to repair. It has definitive meanings right along, like suture, but when you're stuck, repair is your go-to. Control has evolved over time in that initially, when PCS first came out, it was to be used only for post-operative bleeding. But I don't know why they did that. It's useful in any, so acute, automobile accident when patients brought in just to control their bleeding. But we'll get into more when you don't use these when you could get something more specific. So if a definitive procedure was performed to control the bleeding, you would use that definitive procedure, not control. But we'll get into that when we talk about each of these. So next slide, please, Japera. Control. Stopping or attempting to stop post-procedural or other acute bleeding. So other acute bleeding was, after much deliberation at the coordination and maintenance meetings, they agreed to add other acute bleeding. So the site of the bleeding is coded as an anatomical region. They don't get into the nitty gritty, what artery or what vein was bleeding, and not to a specific body part. Control of bleeding of a cut or eroded body part is coded to the body part where the bleeding was controlled rather than to a vascular system body part. When control of bleeding is performed during a procedure, it may be inherent. They always do that. They're always going to control bleeding, so it's part of the procedure to the procedure and not coded separately. It's when the patient is returned to the OR typically for bleeding, like a wound dehiscence. Patient's up in bed recovering. Nurse notice the bandages are bloody. They take him back to the OR to find out what's going on, and they may never identify the particular specific vessel. Um, uh, 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 but you would go to control the bleeding, abdomen or whatever the particular thorax or lower extremity. When when a question, when in question, review all documentation and query the physician for specifics. Always better to use a more specific code, but typically they just, like in an emergency, they want to just stop the bleeding. They're not going to get into the nitty gritty. They just don't want the patient to bleed out. So they probably don't even remember what they cauterized or sutured off. Next slide, please. So here's a guideline about it. If an attempt to stop post-procedural or other acute bleeding is initially unsuccessful, and to stop the bleeding requires performing any of the definitive root operations, such as a bypass, detachment, excision, extraction, reposition, replacement, or resection, then that root operation is coded instead of control, because that's the end point. The intent is to stop the bleeding, and it takes all the way to that point of maybe amputating the limb or removing the spleen. For example, resection of a spleen to stop bleeding is coded to resection instead of control. Next slide. I want to leave some time for questions. Is that it? We're done?
It looks
Oh,
like we have a
oh,
few more slides. James, do you want
okay.
to?
All right, good. I didn't see it move, so I didn't know. I'm sorry. That was me. Don't mind me. So repair. So restoring. So repair. This is your general default kind of, all purpose when all else fails. Restoring to the extent possible a body part to its normal anatomical structure or function, used only when the method to accomplish the repair is not one of the other root operations. This is your last resort, but like a colostomy takedown, because they do a lot with that. They remove the device and they sew up the opening, close off the opening, or suture of a laceration. That's most commonly all suturing for lacerations or repair. But when there's no clear, distinct how they repaired something, and you can't get your query answered, or it's your go-to code for a lack of specificity, but it's used quite a lot. It helps me with what I do. I do a lot of mapping from foreign code sets to the US code sets, and it's apples to oranges. So a lot of times this repair will save the day because the intent really was to repair something. And even though the means may be stated, there's not a good way to capture it from one code set to another. Even going from CPT to PCS, it's very difficult. Next slide, please. So procedures with other object, alteration, creation, and fusion. Next slide. So this is alteration, modifying the anatomical structure of a body part without affecting the function of the body part. So it gets a little sticky. Principal purpose is to improve the appearance, but don't think it's purely plastic surgery or cosmetic, because they can use alteration after a car accident or just some deformity or birth defect. So a facelift that would fall into this, or breast augmentation would fall into this as well. Typically, it is used in the for cosmetic type things, but a lot of coders get hung up on that, so they bring a patient in to correct some defect or birth defect or anomaly or some, it still would be alteration, even though it's not for cosmetic purposes. Next. Creation. There was debacle over this too, because originally it was intended to be used solely for gender reassignment. But then cases came up with pediatric surgeons where babies born without a particular heart valve or some, septoplasty type things, where they're creating that part of the heart from some other tissue in the vicinity of the heart. So finally, after much deliberation, they allowed it, which I was a proponent of allowing it for other things. So putting in or on biological or synthetic material to form a new body part. So here you're making a new body part that previously did not exist. So it's not a replacement. That to the extent possible replicates the anatomical structure or function of an absent body part used for gender reassignment surgery, and also corrective procedures in individuals with congenital anomalies, expanded to also include creation of a structure in vascular anomalies, parts of the heart, like a septum. They don't have any septum of the heart, and they created the new septum for a neonate. So creation of a vagina and a male, creation of the penis and a female, creation of a right and left uh, arterioventricular valve from a common arterioventricular valve. So usually they use something in the vicinity of the heart to create another. In addition, they're down one valve, they use another part of the other valve to make another valve. Next slide, please. Fusion, like spinal fusion, just what you would think it is, what you think it is, joining together, but it doesn't fit into any other categories of root operations, joining together portions of an articular meaning as in joint, body part, rendering the articular body part immobile. So it always involves joints, articular. So the body part is joined together by fixation device, bone graft, or other means. There's different ways. A lot of times they'll use a bone graft in spinal fusion, but sometimes they do use hardware fixation devices, spinal fusions, ankle arthrodesis. Arthrodesis is just another word for fusion. Next slide. Body part characters. Okay, next slide. So that it's the fourth character, and it defines a specific anatomical site where the body. So the second character is the region. The, the fourth character is a specific body part. There are 34 possible body part values. All the numbers and all the letters except O and I. Next. Approach. This is the fifth character. Next slide. And this defines, I go back one, please. So the approach defines the technique used to reach the site of the operation. There's 7 different approach values for the fifth character. This is a very useful one. Next. Approaches through the skin, or again, they can be categorized: open, percutaneous endoscopic. They go through the skin and or mucous membrane. Next. And open is they literally cut. They would have to cut into the mucous membrane through the skin and any other necessary layers. And once you're open, you're open. So if they did something, they started off trying to do it percutaneous, but then they ended up having to open the patient. The final approach is open. Next. Percutaneous, just what you would think, entry by puncture with a minor incision and instrumentation through the skin or mucous membrane and any other necessary layers, like a needle biopsy of the liver. Next. Percutaneous endoscopy, it's the same. They puncture, minor incision, but they visualize. They use technology, the scope to better visualize. Say like a nerve or a vessel, something that's more finite. They really need to see that up more closely. Next. Approaches through an orifice, either via natural or artificial opening, via natural or artificial opening with a scope, and via natural horoscope using a needle and the scope. Next. And obviously some of these wouldn't apply to every section or part of but even like a transbronchial biopsy of the lung, that would be via natural orifice with the scope endoscopically. So entry entry of instrumentation through a natural orifice, opening to reach the site. So they go right down your throat, or through the urethra, where there is an opening transvaginally. Next, now I've got to move it along a little bit. And the only difference here is they use the camera, like a sigmoidoscopy, a colonoscopy. Those are good examples where they use they're going through a natural orifice, but they're using the camera to visualize. Next. And there's some special ones, like via natural with percutaneous endoscopic assistance, like a laparoscopic assisted vaginal delivery. So they do a little bit of everything. They go through the natural orifice, but they make an incision or insert instrumentation, and they use the camera. So you see that a lot with these laparoscopic assisted vaginal hysterectomies. Next. External is just what it sounds like, a closed fracture. They manipulate, like what we would call manipulation. They move the fracture into its right place or the joint without making any kind of incision or opening. So there's no puncture, no cut. Next. Device character. Next. Again, the thing here to remember is that it has to remain in the patient. That's the term. Any device that remains after the procedure is complete. Any instruments used, like a clip put there to stop the bleeding, they take it out, the patient sewn up. That's not a device. Next. So your biological or synthetic, like an IUD would be a good example of that, or your joint prostheses even as a device, or anything that's left in a pacemaker is a device. Next. Therapeutic materials, a device, like a synthetic skin graft, and they can be removed. Another feature of those is they could be removed, if need be, and they take the place of and functionality, the performance of the body part, the initial body part. Next. So, drainage device, radioactive element, because these things will remain in and they could be removed if needed. And some of them are biological, like the autologous skin substitute, and some of them are not, like a synthetic substitute or a drainage device. Next. Qualifier, the last character, the seventh character. Next. So they add some information that defines an additional attribute to the procedure performed when applicable. They have a narrow application to a specific root operation. It usually leads back to the root operation, the body system, or the body part. Next, like when they do a bypass, what are they bypassing to? Type of transplant, like porcine, bovine, human. Second site for a bypass, like I said, or if it's diagnostic, EX, for a biopsy. Next. Sorry, we're running over. And here are our references. The PCS book itself is very good, and the actual book, like I said, and then the code set itself. The reference manual is really very good. It's a little outdated, but it gives a lot of good examples. Okay, next. I think that's it. Just wanted to give those references because they're good. Are there any quick questions before we break?
Yes, we do. We do have a question in the chat.
Okay.
Clark wants to know, do you think that the ICD-10 PCS code book is more beneficial to learn from in comparison to the encoder? So which one do you think is more beneficial?
I myself, it depends on you. But I like to have the book in hand. But you can, at the encode, especially I know 3M, you can bring up the actual tables, and the book is embedded in there. So whatever works for you. I like to have the book in hand, and certain editions do have, like at the beginning of each table, it'll list out, like, for depending on what you're doing or how you're learning or what you're going to do with it, it'll list out in list format all those values that are available in that particular, you know. I like to see, I don't, I gotten used to using the electronic format now. I used to really have to have the book in hand, but now I find it more cumbersome. I really do like it online. But sometimes when you're learning, you can make notes, mark it up, highlight, like a textbook almost when the actual book. They're expensive. That's the downfall. So,
Outstanding. And those are the only questions. That was actually the only question that I saw in the chat.
okay,
So I
good.
don't see any other questions. And I want to thank you so much, Jim, for providing us with this wealth of information. You've been with us for 2 months now, breaking
I
down
know.
ICD-10 PCS, and it's been wonderful. Yeah. So
Getting to be a
everyone,
squatter.
you need water now?
No, I said I'm getting to be a squatter. Just hanging
Oh,
around.
squatter, taking up all the space. I got you. So listen, everyone, thank you so much for joining us for today's Brunch and Learn. We will have one coming up next month. So please make sure that you follow our social media accounts to stay tuned and stay up to breast on what we have coming up at the Qualified. So we have our Instagram, YouTube, Facebook, and also our LinkedIn handles here on the screen. And then finally, our final Brunch and Learn for 2023 will be with Miss B. Martinez. She's going to talk about volunteering and getting involved with some of our local, regional, or state associations, wherever you may be. So please do join us for next month's final Brunch and Learn for 2023. We do have a lot of great Brunch and Learns in store for 2024, but we want you to stay connected with us. And if you particularly in our audience are interested in presenting and sharing your expertise, please email events@the-qualified.com. So until next time, everyone, we want to say thank you, continue shining bright, and we will see you at the top. Have a good day, everyone.
Thank you, everybody. Bye.